You're listening to Aging Uncensored.
Welcome back to Aging Uncensored. We're happy to have you back. We're the podcast where we dive into all things aging, and we're fortunate to still have Dr. Andrew Duxbury with us. He hasn't peaced out after our first episode. He's still with me here. So what we're going to dive into today is VA, Veterans Affairs, home-based primary care. So Dr. Duxbury has been a home-based primary care provider through the VA for
long time.
Very long time.
Okay. We're going to give a little bit of a history lesson here to kind of understand what the VA program is and how it came to be.
Yes.
Because it's very unique. There is nothing else like it in the U.S. healthcare system.
That's right.
The VA home-based primary care program dates back to the 1970s. Mm-hmm. So it's really 50 plus years old at this point.
And that was well before there was really any formal home care services.
Correct.
I mean, that's like way before its time, right?
Yes, because I started doing house calls out, in a system outside of the VA in the early 1990s. Mm-hmm. And at that time, the American Academy of Home Care Physicians were holding their annual meeting in a classroom. Nationally, I mean, nationally, there were like 35 people.
That's awesome.
Yeah. So it was very much its own thing. It predates any of the other kind of physician at home that's happened over the last few decades, because its goal was very different.
Yeah.
The VA began to notice in the late 60s and in the early 70s that there was a certain population for whom they were responsible that could not keep regular appointments to see the doctor. And the only time they would show up is when the ambulance brought them into the emergency room in extremis, and often with things that could have been prevented or mitigated had there been attention done earlier.
Yep.
And the VA being a closed system where they are responsible for inpatient, outpatient, and long-term care costs of their beneficiaries, started to recognize how much money they were spending in inpatient costs and, more importantly, in long-term care costs, where people were having to be placed simply because they could not access a doctor.
Gosh.
And these dollars were adding up. The VA is the only place in the U.S. healthcare system where a central entity can look at the balance between inpatient, outpatient, and long-term care at the same time and understand, if we do a change here is how it affects these other two areas. You cannot do that anywhere else, because in every other part of the U.S. healthcare system, inpatient and outpatient tend to be very siloed.
So siloed. Yep.
And long-term care is a completely separate industry.
That's right. Exactly.
So with this understanding, they put together a model of providing care to veterans outside of the veterans having to come into the doctor's office. And the model was designed to be, let us provide doctor's office services in the home.
Yeah.
And this was to be a long-term, ongoing relationship. And so their decision early on was that it was to be based in principles of case management rather than just on doctoring. And so the doctor or the nurse practitioner or the medical provider is not the center of how this program works. Mm-hmm. The center of how the program works is a well-trained case management RN.
Mm-hmm.
A home-based primary care RN has a patient load of roughly 30 or 35 patients. That is their full-time job. is to ride herd on that relatively few number of people. And because they've got relatively few people, they can go and spend several hours in the home every couple of weeks, educating, setting up pills, making sure that the family are doing things appropriately, that all of the nursing is working the way that it should.
That gives them a tremendous amount of time to build rapport.
Exactly.
Because they're like, that is the person who sees me every 2 weeks. Something's wrong, call them.
Yes. And it builds a relationship between this nurse and this family system where the family system begins to trust. They become more open to doing things in different ways.
Yep.
And after some months of that nurse coming in and gently adjusting how that everything works, things stabilize.
Wow.
And there is still going to be, an acute illness or an injury that's going to require an emergency revisit or something.
Sure.
They're not going to be able to come in and fix their broken hips.
Sure.
But the things going out of control for little things adding up gets nipped in the bud. And so the chronic medical illnesses, when you have a trained nurse who sees this person all of the time, they know when something's wrong.
That's
and
exactly
they know
right.
when there's something is starting to go off balance.
Right.
And they can send the red flag up the pole so that something gets done before everything falls apart.
Right.
As time has gone on, the VA has realized that to really give good service, it requires more than just the nurse. You have to have somebody with more medical knowledge than the nurse, so you have to have a provider of some sort, a physician or a nurse practitioner. And they don't need to go out that often. I mean, I usually go out roughly every 6 months, which is similar to how often people come to see me in the office. It's roughly the same thing.
Right. That's right.
I'm checking to make sure everything is okay and looking for problems that we can do something about before they become big problems.
Yep.
I often have more to do when we first admit somebody and everything is kind of a mess and there's stuff that has to be done. But once everything is in place, the treatment plan has been decided upon and that things really calm down. We have a social services person who interacts between that veteran and all of the different VA programs that may be available to them, and is also knowledgeable about community supports in whatever local community they may live in, so that we can pull in things that are not necessarily VA, but which they are entitled to.
So does the social worker see them in the home as well?
The social worker sees them in the home.
Okay.
Roughly, again, every 6 months.
Sure.
We have a dietitian who goes out and will educate families on particularly diabetic-friendly diets.
Sure.
Diets to help with renal disease, diets to help prevent exacerbation of congestive failure because there's just too much sodium.
Yeah. Yep.
And we go out not saying you got to eat like this.
Right.
It's much more of a process of, your sugar's out of control. Well, there are 6 cases of Mountain Dew sitting here under your kitchen table. Maybe if we could at least switch this to diet.
Yeah, that's right. Absolutely.
We have an occupational therapist who does not go out and do exercises with the individual, but who is an expert in home safety, home modification, and medical equipment.
Oh.
So it's trained eyes who really know what they're doing to make sure that it's the right walker,
That's
that
amazing.
it fits properly, that if they need a power chair, we can shepherd it through the system and get the right kind that they can actually safely operate, that will actually work in their house the way it is designed.
That's amazing.
There are VA programs, for instance, that will free up money for remodeling a bathroom to be more handicapped accessible, and they can help with that process.
Wow.
We have a mental health psychologist or psychiatrist, which will help not just with the veteran, but with the whole family system in terms of counseling.
Wow.
And we have a pharmacist.
Oh, a pharmacist is such a great
Yeah,
asset.
now the
to a
pharmacist
team.
does not go out to the house, but the pharmacist does a full-blown medication reconciliation on a quarterly basis.
Oh,
on
wow.
everybody.
That's awesome.
They catch everything.
Everything.
So we know we've got the meds right.
That's amazing.
They are also, because they don't go out, they're the ones who are constantly in the office.
Yeah.
They're the ones who first review outside medical records that come in.
Oh.
So if they were hospitalized or saw an outside physician, those records come there so that they can pick up what the changes were in the medication.
That's amazing.
And then if it's something that they don't, above and beyond that, they'll push it off to whoever else needs to know about it. But usually it's med issues that are the problem. One of the big roles of the occupational therapist is fall prevention.
Uh-huh.
You know, what do we need to do about this person and this household and equipment and family education to try to reduce that? Because, you know, in 35 years I've been in geriatrics, the two things that I've learned there you can really do something about, make a difference, are preventing falls and getting the meds right.
Yep, that's exactly right.
Those
can go hand in hand.
Yeah, and those are the two biggies.
Yep, absolutely. So what do you do? So I have lots of questions,
Yeah, so
but
this program, because you've got all these salaries, is very expensive.
Sure.
Nobody else can run it because you've got all of these people going in. Now, the nurse only sees 35 patients.
Yeah.
But like the medical provider, I am over five nurses directly and another 4 indirectly.
Okay.
So I've got whatever that is, 200 or 300 that flow up to me. The occupational therapist, I think, covers 6 nursing teams, things like that. So it's only the nurses that are that intense.
Yeah. Because there are definitely other home-based primary care programs that do wonderful work, but the VA model is what is unique.
Yeah, absolutely.
The interdisciplinary team, all the resources that are available.
I'm basically saying we're basically a whole clinic building on wheels.
Right. Absolutely. So how do you get signed up with the VA home-based primary care?
There are 2 things that are necessary. One, you have to be eligible for VA health benefits. So you will have to have, gotten signed up within the VA health system.
And if you need to know how to do that, we have a podcast. You can
call your veteran service officer for your local.
That's right.
And they will help you determine whether you have eligibility for VA health benefits. And if you do, then they can help you get signed up.
Yep.
If you were signed up, then they will assign you to a primary care provider within the VA, and you can ask that individual to put in a referral to the home-based primary care program.
Perfect. So once the referral is done, how do you qualify? Who's
once we
prioritized?
decide, either you have to be homebound.
Okay.
If you're busy driving yourself into the clinic, and to Walmart,
right,
and taking yourself everywhere and you're perfectly independent, you're not somebody we need to be taking care of.
And homebound typically doesn't mean you cannot leave your home.
No,
it means there is a significant effort that has to be given to leave your
taxing
home.
effort.
You need assistance from a person. It's homebound is not someone who's driving themselves to Walmart or.
So, because my piece of the Birmingham VA home-based primary care is the rural areas, not greater Birmingham.
Yeah.
A lot of times I'm taking care of people who live in these tiny little towns. They could drive to the Walmart, which is a mile away.
Yeah.
They can't drive the 26 miles to the most convenient VA clinic.
That makes sense. Yeah.
So all that enters into it. You have to be willing for all of us to come in and see you.
Okay.
If you don't like people in your home,
it's not for you.
This is not for you.
Yeah. So you have to be willing to see all the team members?
Correct.
Okay.
Now, as I said, the only one that comes routinely is the nurse. Everybody else.
Okay.
I mean, there's a big kerfuffle at the beginning to get everything set up.
Sure.
And then everybody more or less goes away most of the time, other than the nurse.
Gotcha.
But you have to be, willing for that. we will take people that are somewhat marginal and we will help them get better. We will graduate them,
Yeah.
which is a good thing.
It is a good thing. Be able to set them up with the resources they need from the VA to get better and to get to a clinic. What if they need to see a specialist within the VA? How do you all navigate that?
We set them up for specialty care in the same way that we would set anybody up. I cannot get the specialist to come to their house.
Right. Yeah.
We help determine, does it make sense, given who you are with the function and medical problems you have, to actually see this specialist?
Yeah.
If it does make sense, then we will help arrange transportation to get them to the VA. Under the community cares program that Trump put in his first term, we can oftentimes get people in to specialists not of the VA who may be more convenient, so they don't have to go all the way to Birmingham if they're living, dozens of miles away.
Yep, absolutely. So can you have other home services when you have this?
Yes, because most other home services are paid out of Medicare pot,
right?
Not out of the VA pot. They are two separate pots of money. Therefore, it is not a duplication of services.
That's wonderful.
So we use Medicare home health all the time because our nurses can come out every 2 weeks.
Sure.
They can't come on a daily basis for, monitoring wound care and things of that type.
Sure.
We farm that out to Medicare home health.
To home health, like other places.
We don't have ongoing physical therapy for someone who really needs it. We farm that out to Medicare home health.
Gotcha. And patients do you have patients with VA home-based care that have hospice as well?
Yes.
Okay.
When we try not to admit someone to the program who's already on hospice because we can't really add much to what hospice is already doing.
Right.
If it's someone we've been taking care of for years, we will facilitate their admission to hospice when it is time. We don't go away.
Gotcha.
But we kind of drop into the background.
Yep. And be available.
And are available. The hospice handles most of the day-to-day, but our nurse will still come out every few weeks to check up on things because there's usually a long-term relationship.
Yeah, absolutely. So do all the VA medical centers have this? It
exists in large portions of the VA. Pretty much all kind of urban VAs have got a home-based primary care. Birmingham has been working diligently over the last 15 years or so to expand it so that we can offer it to everyone within the Birmingham catchment area, which is all of north central Alabama.
Oh, yeah.
So when I first did Birmingham home-based primary care back in the late 90s, early 2000s, it was only available to greater Birmingham.
Okay.
Since then, we have added teams based in Jasper who cover kind of the I-22 corridor, teams based in Guntersville who do kind of the north central down to Gadsden.
Yeah.
Teams in Huntsville who now do Huntsville Metro, and teams in Childersburg, which kind of go kind of Clanton to Oxford.
Yeah. Yeah. Wow, that's awesome. That's amazing.
And in order to completely cover the area, we need to get teams in Muscle Shoals.
Yeah.
And then in Oxford to be able to get all the way over to the state line.
Yeah. Okay. That's amazing. What about like labs, X-rays?
The nurses will draw lab.
Okay.
The nurses will do vaccinations.
Okay.
They'll bring out the flu shots.
Yeah.
Things. We have a protocol for routine lab draws so that we know we don't miss something. Everybody gets a lab, a lab draw on certain things on an annual basis. If there's certain diagnoses, it moves up. X-rays, we use the mobile X-ray services that everybody does. The VA does not have its own independent. We'll call them up.
Right.
And do it. And the VA can pay for that, or their Medicare can pay for that, depending on what makes the most sense.
Gotcha. Good. That's amazing. So when you, as a provider, go to see these patients, do you go with a team when you go? Who's
Well,
usually
back
with
in the
you?
day when I first did it, it
Uh-huh.
was the clown car. Everybody went at once. It was home invasion.
Sounds like a lot at one time.
It was, and that we no longer do that. I mean, I go with one other person.
Uh-huh. Okay.
And usually the case management nurse.
That's much more reasonable
Yeah.
than 10 people.
Yeah. And so a lot of times as to how many people will go to a visit, some of it will depend on safety for us,
Mm-hmm.
because particularly in rural Alabama, there are some rather interesting individuals
Certainly.
living very interesting lives. I can now identify a meth lab at 200 paces. And, just we want to be sure that everybody is safe. We do not pass judgment on anybody and how they live their lives.
That's
we
right.
see them no matter who they may be.
That's right.
But, we are also cognizant of certain issues that might arise, and we want to avoid them if we can. The only thing that we will really refuse to go into a home for is demented people with unsecured guns.
Yep. That is that could actually be a whole podcast episode.
I've only had to take a gun away from a demented person once, and that was one time too many.
Yeah. Oh my gosh. I can't even imagine. No, that's really reasonable.
Yeah. For the most part, other than that, I mean, if they've got bed bugs, we'll put on PPE and we'll deal.
I know. That's what you do.
Yeah.
Yeah. So, I mean, this is amazing. So if you are interested in VA home-based primary care and you think you may qualify, do you have to go see someone in an office first? Is that?
You have to be put into the system. And
Okay.
The system does not allow your first visit to be
with VA home. Okay.
primary care. You'll be assigned to somebody who's in primary care. Now, making that initial visit is going to be a disaster.
Right.
You can always call the office of the person you're assigned to and say, I really can't do this. Can you please put in this referral?
Okay.
They can do it.
They can do it. Okay. All right. That's good to know. I kind of always thought you had to go in first, which I was like, oh, what if you really can't?
If you really can't, I mean, they can put the referral in.
Okay. Okay. Good to know. Good to know. And I love the fact that there's a social worker who knows the ins and out of all the VA programs, because
They are bizarre.
I mean, that's incredible. That's an incredible resource to have. I mean, because those programs are often changing and there's more resources, and I can't keep up with it.
No.
I know just a little bit, and
Given our current administration, who knows what they're going to look like a year from now.
right, exactly. So so that's wonderful. That's amazing. So VA home-based primary care, if you qualify for VA medical care,
And it is
homebound.
really, really tough for you to, get to the doctor.
Yep.
It's an option. You have to be homebound. You have to be in a geographic area that is serviced by the program. There are certain rural areas in northern Alabama that we can't get to yet. As I
Sure.
said, we can't get up to Florence Muscle Shoals.
Yeah. What about, I didn't ask about this, but what about, I know home, of course. What about assisted living?
We can see
Memory
people in
care.
senior living, independent, and we can see people in assisted living. Because
Okay.
again, legally, that is the same as
Thing
if
as
they're
a
living in their own
home.
home.
That's right. Yep.
Yes, so that's not a problem. We cannot go into skilled nursing.
Okay. Yep. That makes sense. And in skilled nursing, they're going to have access to medical
Yes.
care and things like that. So, okay. So if you qualify for VA benefits, you or your loved one are already being seen at the VA, you're homebound, you need to ask your provider about a referral to the home-based primary care program. It's a great resource.
We're open for business.
Okay. Good to know. Wonderful. Well, thank you so much for sharing that. That was,
Absolutely.
I mean, I knew about this program and have known about it for a while, but I learned several things today. So I really appreciate your
Oh,
time.
it's a great program, and it's like nothing else in the country. So
Yeah.
anytime I see someone who I know is in trouble at home,
Yeah.
VA benefits.
Yeah, absolutely. Absolutely. And I am a firm believer in home-based care. That's been the majority of my career as a nurse practitioner. And we're going to have lots more to come about home-based primary care and home-based care
There's
resources.
so
to
much
come.
that you just learn from walking in the door that
Oh
you cannot
my
possibly
gosh.
know.
There are
in the
100
office.
questions you do not have to ask.
Exactly.
100 questions. When I worked in the clinic and we would have patients come in and they would come by themselves or everything would just be a mess and you'd just be like, they couldn't really tell you what was going on. You'd be like, oh my gosh, what's happening here? You do one home visit and you put all the pieces together. So it's what's best for the patient. I think it's what's best for the family, the provider. It's just the best thing.
Yep.
So, well, thank you so much.
My
I appreciate
pleasure.
you. So that's all we have today. Be sure to like, share, subscribe, tell your neighbor, tell your friends about Aging Uncensored. Thank you so much for joining us.